You. Well, if you are here for Success with CHW's Oral Health Roadmap, you are in the right place. Thank you so much for joining us for this breakout this morning. My name is Joan Cleary. I'm with the Minnesota Community Health Worker Alliance, and I'm here with our wonderful panel to talk about the CHW role in oral health. And so I'm going to start out with some introductory remarks, and then we'll turn it over to my fellow panelists, who include Dr. Jeffrey Karp with the University of Minnesota, who will talk about CHW's perspectives from a pediatric dentist. We then will have Ann Copeland from Community Dental Care talking about CHW's members of the oral health team. She'll be followed up by senior health educator and CHW Lou Yang, also from Community Dental. And then I'd love to share with you some recommendations from the Alliance's Oral Health Roadmap for CHWs. So I'll get started just with a couple quick words about our Alliance. We serve as a catalyst, convener, go-to resource, partner, consultant, and we're all about equitable and optimal health outcomes for all communities, and that includes oral health as well. We know we have a lot of work to do to ensure that we have better outcomes around oral health. So our mission is to build community and systems capacity for better health through the integration of CHW strategies. So what are we trying to accomplish then? Kind of saying it differently is by fully integrating CHWs into Minnesota's systems of care, including oral health, we aim to reduce health disparities and advance the triple aim. I won't go through this slide every word, but just want to make sure we're all on the same page on what is a community health worker. And basically, CHW is a trusted frontline health professional who applies his or her training and unique understanding of the experience, language, and or culture of the populations he or she serves in order to carry out a variety of roles. And these can include health education, this can include advocacy, can include care coordination, a variety of services that really address key gaps. So CHWs are uniquely equipped to advance health equity in the triple aim because they bridge health and social services systems, including oral health, and the community. They typically come from the community they serve, and they're typically not licensed clinicians. So it's really an emerging health profession that has its own distinctive competencies and background. A little bit confusing, but important to know that CHWs work under many different titles that make sense for the kinds of organizations that they serve. So you may see some of these titles in the Latino community. CHWs are called promotores. In the American Indian community, they're called community health representatives. And again, other titles you'll see here and many more. And then CHWs work in many different places. One of the things that differentiates their role a bit is that they do a lot of work in the home and in the community. So they can extend that great work that you're doing in the clinic, in the hospital, in the dental office. And as you can see here on the slide, we've captured that with a dental office here in this particular schematic. And you can see the kinds of functions that CHWs perform in the community, in the home, and in clinic and hospital and other environments. So in Minnesota, we have some key building blocks. We have a CHW scope of practice, and that helped inform our statewide standardized community-based curriculum that's offered by a network of schools in Minnesota. And we're very proud to say that the curriculum includes an oral health module, because those who developed the curriculum felt it was so important that CHWs be acquainted with oral health, given the work that they do with communities that are experiencing disparities in particular. And we also have payment under Minnesota healthcare programs for CHW services specific to patient self-management and health education. CHWs also who are certificate holders who've completed the curriculum and who have training in applying fluoride varnish may also be paid under Minnesota Medicaid for that service. So I'm going to stop here. I'll kind of rejoin the panel at the end. We also want to have some Q&A time at the end, and I'd love to turn it over now to Dr. Karp.
So my name is Jeff Karp. I'm a pediatric dentist at the University of Minnesota, and I also direct our residency program in our clinic as well. And I came to Minnesota about 4 years ago from upstate New York, and so I have some unique perspectives on community health workers, being involved in several projects over recent years. So I'm just going to kind of give you some perspectives that I've had over the last decade or so, involved in a series of projects, and that will hopefully inform some more of our discussion about potential uses and ways to implement the use of community health workers, at least in pediatric dentistry. So my professional journey takes me initially from North Philadelphia, where I did my dental school training. I'm originally from Pennsylvania, and then I moved to Columbus, Ohio, where I did my pediatric dentistry training in urban Columbus. But we served many kids throughout upstate and around Columbus, Ohio. And then we moved from there to Rochester, New York, so about 6 hours away from New York City. And we had many of the same challenges that we face here in Minnesota. A lot of rural communities, a very small metropolitan area where we were providing a lot of the care. And then as I moved here, so I've been in places where I've been living in urban communities, connected with urban healthcare systems, large children's hospitals. But I've been very much involved in providing care in community-based situations, and also trying to develop relationships between community and university, and also community and children's hospitals. So that's kind of where my experiences have come from. So my first perspective comes from some training I had, or some work I did in upstate New York, and it's that visibility and accessibility enhance utilization of oral health services. So to give you some idea of what I'm talking about, I was part of a program at the University of Rochester called the Strong Teeth Program. It was aptly named because the hospital was called Children's Hospital, Galveston Children's Hospital Strong. So we were just an oral health program within that unit. And we had a program where we worked, our group as pediatric dentistry worked with primary care pediatrics to develop a relationship so we could develop same-day walk-in service for oral health services. This goes back to 2005, 2006. This was before the time when, at least in New York State, medical providers could provide oral health services. So we worked on relationships there to help facilitate the movement of patients from the primary care clinic, which was on campus, at the medical campus, to our clinic, which was also on campus. It should not have been an easy task to do this, or should not have been a hard task to do this, because patients were already on campus. It was just simply walking through a few buildings, across the parking lot to get to our building. But we found the rates of both referral and utilization were very low before this program. So we worked with a joint partnership with our Division of Social Work, General Pediatrics, and also Pediatric Dentistry, to try to enhance these services, both referral and utilization of pediatric dental services, especially for children under age 2. And so you can see here, and these are just some figures from that project going back to 2003, where you can see in 2002, 2003, before we had any type of project, we had both low referrals and we also had low utilization or attendance. The introduction of a community health worker, which at that time we called an outreach worker, helped to increase both referrals and utilization because they were physically present in the primary care clinic. They were visible, they could speak with families, and they could help to facilitate the movement of the patient from the primary care clinic over to the pediatric dental clinic. The problem at that time was we weren't really prepared for that. And so although we were accessible and on campus, our systems were not in place to actually help the community health workers make that even more of a streamlined navigation. So you can see we made some improvements, but it was still cumbersome. So we weren't seeing the rates that we needed to see. Then as things go, a lot of times with grant-related projects, we lost funding. And so at that time, we didn't have a community health worker, but we had improved our processes. So when we did get referrals, we were able to utilize the care a bit better. So we have that in place now, but we didn't have a visible source. And so, obviously we sought more funding, and that was really important. And I think at that time it was the New York State Department of Health which provided funding. And you can see that as we then had funding and the systems in place, we became both visible and accessible and saw dramatic increases in both the number of patients referred every month. We also saw dramatic increases in the age of the patients lowering to younger age groups through the last 3 years of this project. And then we saw much greater stabilization, which we found to be important. So that was a take-home message for me was, whatever we're going to do, visibility is important, and also having good systems in place, which can help to facilitate the transition of care. Am I not loud enough?
Just turn that on. And I've got the video mic right here. If you could work more in this area.
Okay,
pick up,
sure.
Let's just see if this thing is not picking up. Not sure. Maybe I've got to kill the other one. Is the other?
It's over there. Sorry about that, guys. Okay. All right. So then, so I'm still in upstate New York at this time, and the second perspective I have was I joined into a program working with federally qualified health centers in upstate New York with the goal of providing teledentistry services between rural federally qualified health centers and our urban pediatric dentistry clinic. And so the perspective we had here was that relationships and monthly review were more important than the technology. So this was a teledental program between Rochester, New York and Geneva, New York, which is in the rural communities. I was working with a group called Finger Lakes Community Health, and I worked at the Eastman Dental Center. And so this was a collaboration between pediatric dentistry, our federally qualified health centers, and then some other community organizations which were also helpful. This was funded by multiple organizations, mostly on the telehealth side to pay for infrastructure. And as you can imagine, in a telehealth program, we think we can throw a whole lot of telehealth infrastructure at something and it'll just fix a problem. Like if we can see people on camera, everyone's going to obviously then get care. And that's really not the case. It certainly facilitated consultation, which is a lot of what I was doing. But in order to get the children from rural upstate New York into the urban center to receive care required the help of community health workers. And so just to show you a little bit more, this was kind of the map of upstate New York where I was in the red, the Eastman Institute for Oral Health, and then we had all these surrounding clinics and agribusiness, community and children's centers, and other mobile dental sites. And so there was many days where I was doing consultations between 5 or 6 sites without leaving my office on the campus of the university. And so what we found there was that we could certainly screen patients, we could do consultation, but how do we actually get them to care was the real challenge. And so, and this group already had well in place as a federally qualified health center or a group of clinics, they had in place bilingual and bicultural community health workers. And they played such a key role in this project because they were the ones who had built the relationships with the families and with the various organizations we were working with. They were providing transportation, interpretation services, counseling and education, navigation for insurance and other things. And they played a key role in what we called monthly program meetings. And that was a place where every child that was enrolled in our program, we would talk about each child every month to make sure that there was no child falling through the cracks between the rural clinics and our urban clinics. And so we made sure over time that these children would move from receiving no dental care to receiving all of their dental care in a coordinated fashion. And that key role was really the community health worker serving as the liaison for the families to the group of clinicians. And so these monthly program meetings were so successful that the group now in New York, since I've left there, has then gone on and published several reports. And they've also told me that in 2015, they were able to take the children that needed care in the urban centers, and 100% of them reached treatment completion for their oral health needs. And these are kids that are beyond the scope of practice of a general dentist. Many needed sedation, nitrous oxide, the operating room, had extensive amounts of dental disease, and they were able to move each of those children with the help of community health workers through a system that led them to treatment completion, which in my mind is the most important thing that we can do. It's one thing to identify disease, and certainly education is important, but if they have already existing disease, we really need to get it treated. And so that was a really powerful message from my perspective, that even when there's great geographic distance, a community health worker, by building relationships and participating with the clinicians in a process, especially a monthly review, that these children can receive care, that we won't lose them out of a system, and that they can reach treatment completion. My third perspective comes, I think there's a typo on this slide, comes from an experience that I have in Minnesota right now. We have a dental care coordination program with Portico in our clinic at the university. And this one's shared accountability and thoughtful scheduling helps to optimize scarce resources, not scary resources. And so we've had this program. This was started actually before I arrived in Minnesota through a collaboration between the School of Dentistry and Portico HealthNet to utilize at that time our new clinic, which is a Delta Dental clinic that was built through foundation funding, to help to navigate care for some kids that were uninsured. And so we've had this program now for several years, and we're working very closely with Portico and their community health workers to help these uninsured children navigate to our clinic. And so this has been a partnership between the School of Dentistry, Portico, and their community health workers. And so recently we ran some data, one of my residents ran some data on some 2-year results, and we found that at that time, at least children that we could identify through our electronic health record, there was about 60 children in this program, where about 1 out of every 6 came in with pain on their first appointment. Through that 2 years for these 62 children, we had completed 169 appointments, had done about 700 procedures, 295 teeth within this group of children needed to receive care, and about 71% had reached treatment completion. The 2 pieces of data that I think are interesting are, one is in this group of patients, we were able to our community health workers helped to navigate these children to care with our clinic to the point that we have a 7% cancellation or no-show rate, which is about a third of our general clinic population, which I think is really important. So we're actually learning from this model actually how we can improve the attendance rates for our general clinic population. And the second is that we only have about 5% of the teeth still left to treat in these children. So we've been working very hard to help, and we find that the model that helps here is, one, having community health workers to understand the families, to kind of share accountability in making the system work. But the second was in how we schedule the patients. And so we recognized that if we tried to run a model where we just opened up a clinic every day of the week and just said, come when you can, that we might not have the same type of accountability from the families as well. And so we tend to book patients on a more of a short call schedule where they're booked 24 to 48 hours before the appointment's available. And that has also helped because life isn't changing around them as much within that 24 to 48 hour window. And so I think that also plays a role in keeping our attendance rates very high. And so that's kept us motivated to continue to provide care and to ensure that these children are reaching treatment completion. And my last perspective is actually a very kind of evolving perspective, and it's that it takes a village and it takes interpreters of the community to support a dental home. And this is a new project that I'm involved with. My colleagues and I at the university, Peter Scal, who's a public health pediatrician, and Mark DeRuyter, who's a dual-trained audiologist and speech-language pathologist. We recently were accepted into the Robert Wood Johnson Clinical Scholars Program, and we've set out with our 3-year project to be focused on building a dental home network for children with special health care needs across Minnesota. And the 2 innovations that we look to provide through this program, one is empowerment and building capacity through education of more providers to care for kids with special health care needs in dentistry. And the second is to work on the navigation piece by embedding and working very closely with community health workers to help those patients that need to come from our rural clinics and rural providers to more urban centers to make sure they can also reach the care that they need. This is funded, as I mentioned, by Robert Wood Johnson, and then we're also working closely with our leadership group at University of North Carolina. So those are my perspectives. I'll be here to answer questions as well, and I appreciate your attention. Who's next?
Good morning, everyone. I'm glad you all made it through the monsoon rains to get here. I'm Ann Copeland from Community Dental Care, which has four clinics, 3 in the metro area and 1 down in Rochester. And we have just one community health worker so far, but we do have 10 health educators. Lu Yang is going to follow me, and she is our community health worker, health educator, formerly dental assistant. It's a very important part of our team. So, Joan already gave you a really good definition of a community health worker, but this is the definition that is in our Minnesota Healthcare Program Manual, that the community health worker is a trained health educator who works with Minnesota healthcare recipients who may have difficulty understanding providers due to cultural or language barriers. And this definition is important if you want to enroll your community health worker and bill for their services, which we do. We bill for Lu's services, but we have to follow a certain plan, which I will talk to you about. And this is part of the definition that Joan already used, so I'm going to skip that one. But we really have to define who is our community, who is our community health worker working with. And in our clinic, it's many different cultural groups. So I just have some samples here. It's old, it's young, it's Hmong, Karen, Somali, Spanish, Hispanic, many different groups that she's working with. And this is not Lu, but I couldn't find a picture of Lu sitting on the floor eating. Put in one of me. If you want to get to know your community, you have to talk with them, you have to sit with them, eat with them, walk in their shoes a little, and then you will understand them better and be able to come up with solutions that work for them. And Lu was an immigrant who came when you were about 16 from Thailand, from a refugee camp in Thailand, and she has walked in the shoes of many of these people, understands the problems of how to learn how to navigate the system here, how to understand the providers, what they're telling you, how to learn a new language, how to take transportation, all that. She knows all those problems because she experienced them herself. So here's a little background in our clinic. We see more than 40,000 patients. We have over 120,000 encounters per year. So of course, Lu can't help all of them. So that's why we have 10 health educators. But many of them, most of them are on public assistance, and many have very little background in prevention and oral health and healthy eating. And a lot of language difficulties. A lot of them have complex medical needs, and they really don't understand their coverage too. So they come and we tell them this needs to be done, and they think, well, I can't pay for that. They don't realize that actually medical assistance will pay for it. That's one of the things Lu does, is help explain to them what their coverage is. So of course, these are the problems all communities face, but our community has extensive problems here with caries, with periodontal disease, and with some oral cancers. And what they don't understand is, how does the disease develop? Once it has developed, how do I manage it? What am I supposed to do? And again, they need a lot of education and a lot of time, and the providers often don't have enough time to explain all that, but Lu does. She will take the time. So the one thing that we really want them to understand is that it's preventable. So Lu will spend time explaining how to prevent it, and then once the disease is present, it's treatable. And actually, with our population, she helps them understand why it's important to treat it, because a lot of them will say, "My baby teeth, they're just going to fall out, we can wait." And so how does she help the community? Well, she does detective work with the families. She discovers, what are the barriers? Why aren't they coming back for treatment? Why didn't they follow through with their referral? And then tries to work out ways to help them. So maybe the problem is transportation, maybe it's fear. And maybe it could be just be that they don't understand that it's important. So she'll go through and discuss with them, she'll go through their health habits, their oral hygiene habits, home environment, and those other issues. And she'll assess their readiness to make changes, and then help them find solutions, and then help work together with the dental team. Can you hear me? All right. It seems like it's going in and out here. So who is the oral health team? Well, the oral health team is the dental providers, our dentists, advanced dental therapists, we have dental hygienists and dental assistants, but it's also the schedulers, it's the billing staff, it's the IT, the financial coordinators, the health educator, the community health worker has to work with all of those in order to make it work. And the oral health team might have some difficulty communicating. The dentists really know their stuff, but they speak up at this level, and it's hard for them to understand how to bring it down to a level where it actually means something to the patient, and especially when you're dealing in a different language. And this is where our community health worker really makes an impact, because she bridges that gap in understanding so that the patient actually really understands what the provider was telling them and what they need to do about it. The interpreter helps, but often the interpreters don't understand that dental language either, and we find that the interpreter didn't present the information accurately. And so that, again, the community health worker who's from that community and understands that language usually does a much more effective job. And also, understanding the patient's worldview and the patient's perspective is important. This is a medical example, but I just want to give you an example like with the Karen population. If you have a Karen person in the hospital who's about to die, the provider should not tell the patient you're about to die because your words will make it happen. So by saying that bad thing, you might actually make it happen. So what a lot of the Karen Christians, so the better way to do it is to say, you need to tell your family member to prepare to meet God. But that's acceptable. But you can't just come out and say this. What we might say, give it to them straight, but you can't do that. And in the same way, in some of the interactions that our providers have with the patients, they might not know what's culturally acceptable or the right way to say it. Community health worker does. So here's Lou working with a pregnant mom. We really want to encourage pregnant moms to come in, and a lot of cultures discourage pregnant moms to come in. They say you shouldn't disrupt the baby while it's developing, and going to the dentist will disrupt the baby. So what does she do? Our community health worker is assigned advanced cases like children with rampant caries or parents who are resistant to getting the treatment plan done, or patients who are going for OR have been referred and don't know how to work that process, or patients just who don't know how to follow their treatment plan. And she helps get to the root of the issues, and she persuades and motivates. That's a really important thing, is persuading and motivating and helping them realize that she's on their side. She understands the problem, she's on their side. The reason she's telling them this is because she really cares about the outcome, the health outcome. And she works with interpreters effectively, assists the patients with setting goals, and also collecting data. Data is important for us because we need data for our grants and to determine which way our program should go. And then in our clinic, the dentist decides who needs to see the community health worker, has to make an order and order a certain number of units and put that in the chart. And then the assistant will record that and then take the patient to the community health worker. And the community health worker completes that face-to-face assessment we have a little quick note in our electronic health record with the education plan, and that has to be there. She has to put in the in time, the out time. This is important for billing, and if there was an interpreter, and then the whole education plan. And then she helps the patient find resources. So sometimes the patient said, I got a referral here for my child to go somewhere else, but I don't know what to do with it. And then she'll help them understand, maybe even make some phone calls for the person to make sure it happened. And we have some other community health workers, one of whom works at HCMC. That's an important part in the emergency room to make sure that the patients actually don't come back to the emergency room for the dental care, that they find another place to go. And so you're very important. All right. And then this is just a picture of one of the children who came to our clinic. A lot of times the parents say, oh, well, they're not going to do anything about it, it's not important. But what Lou does is many things with the patient. She shows some of them actually how to brush. Some of our patients from refugee camps have not had a toothbrush in their hand before, and they're not even sure how to manipulate it. And she shows them how to floss. And what foods and drinks have a lot of sugar in them, and which ones are healthy, which ones are not healthy. She may even, because she's a dental assistant, she understands the treatment plans. She might even show them what their treatment plan is and why it's important to complete it, and why baby teeth are important. Uses a lot of different tools. This is one of our goal sheets in Karen. So we have it in many different languages, so it's appropriate. And what we really want is the patients to understand what is the main problem, what do they need to do, and why is it important. And sometimes when they leave the operatory and come to her, they know some of that, but not all of it. Because they're only listening with half an ear while they're in an operatory. Somebody's got a mask, and there are all these noises going on, and they're kind of afraid. So finally, when they come to Lou, they're ready to listen. They're calmer. It's a nice, relaxed atmosphere, and now they're listening. And the other thing Lou does is she helps them understand that the true dental home is not dentist. They only come to the dentist probably twice a year. And the dentist can't fix everything and do everything 2 days a year. The true dental home is their own home. And the parents need to be empowered to take care of their children and to take care of their own teeth. And what we're doing is providing them with information and motivation so that they will do that. And so 365 days of the year. And another important role is to calm fear and anxiety, because a lot of the reason they don't complete treatment plans is fear. So when she shows them and explains what to expect, helps them with details like where do I park, or how do I do this, or how do I do that. Once they understand that, then they're more likely to follow through. So now this little patient is going to get treated. Here's the teeth starting to get treated. Now they're done. So the patient actually completed the treatment plan. And as I said, she's encouraging the pregnant moms, because many of our cultures don't want pregnant moms to come, and also encouraging them to bring their babies by age 1 for a lap-to-lap exam. And she's working in the community, helping families in the community, and also in our programs, like here's at a school sealant site, but a lot of the parents are Hmong speakers, and she's writing the results of what we did in Hmong so the parents can understand. And a lot of our programs are funded by people here, Delta Dental, Park Dental, Healthier Minnesota, Medica. We're very grateful for that, allow us to go out in the community that way. And finally, last slide, just realize that it takes time. It takes time for people to buy into that concept. Not everybody's gung-ho about community health workers, and just have patience. Reimbursement issues tend to keep cropping up, but we're working on that. And in our nation, of course, because the dental reimbursements are the lowest in the nation for the adults, or is it the children? Children. It is, it's difficult to get as many providers as we need for the population that requires, for our low-income population, and the community health workers are a good team member here because they help. A lot of people are afraid to sometimes have medical assistant patients because they may not show up or they may not complete their treatment, but a community health worker helps ensure that that happens, as Dr. Karp said. Also, develop your protocols ahead of time, your quick notes, whatever you need. Those are really important to get your system set up ahead of time. And train each type of staff, because if you don't train your front desk, it's going to fall apart. If you don't train the assistants, it's going to fall apart. Everybody needs to know their role. And finally, I just want to show this is we want our patients to have healthy teeth. We don't want to have to even do any kind of treatment, but we sadly end up doing a lot of it. But through our health educators, we hope that more and more children will have healthy teeth like this. So I'm going to ask Lou to come up. She's going to give a little bit of her experiences in the clinic, ways that she helps people. Sometimes they're dentally, sometimes they're not dental. Thanks, Lou.
Yeah, thank you. Okay, well, thank you. Is it afternoon? Oh, it's still morning, so good morning, everybody. My name is Lou Yang. I'm a CHW. My title is actually CHW. I've been in CHW ever since 2005. Recently this year, I'm actually part of the CHW leadership. And thanks to Joan that she invited me to attend this, so I've actually had 2 titles right now, right? 2. I've been working with community dental care for almost 11 years. I used to be a dental assistant with Dr. Peterson, she's right there. And before I came to Dr. Peterson, I had no idea how to take care of my teeth. To be honest with you, I came to this country back in the 80s. That time I was 15, like I mentioned earlier. And I remember that I had been going to the dentist, but where, I don't remember anymore. But I know that I do have cavity. That's all I know. And that was it, treated, done. Never have been told or educated to go back, and every 6 months, and or how to brush it, or to floss. So that was done, went on, life went on. When I came back to Dr. Pearson, I said, oh, that's how important it is. If I want to keep my teeth, I had to do a good job. So then I said, okay, let's do myself first. So I took care of myself. I brush it more than 3 times a day, believe it or not. Just so that I have my teeth to talk to you guys. I worked with Dr. Pearson before I had my first child. And so I said, okay, I'm going to do the best I can, because every time I go to a medical doctors, they didn't ask me if I already have my child see dentist or not. Okay? And so they said, well, but I work at dental office, so I should know that. So let me take care of what I know, and also go to dentist as I know. And he'll be 24 very soon. He doesn't have any cavity. That is pretty good, right? Okay. Thank you. And let me tell you too, my last one, she'll be 15 soon. And who takes care of her? Me, my husband, my sister. She has more cavity. Why? Because we don't have time to take care of children now, right? These days? We are really busy, okay? And so become a dental assistant, become a mom, become a CW, a wife is not easy. I know everybody of you are same boat like me. I have been basically CSW ever since I came to this country, I would say, but just that we don't have those names or the title those days. I was actually interpreter for my mom, for my family, in the hospital, in the clinics, in the Social Security offices, even helped to apply for Social Security income for some of the neighbors and for my one of my cousins. And I don't know how to navigate it, but I I did it. Nobody teach me like these days, that at least somebody teaching somebody. But those days we are self-teaching ourselves. And I have one of my coworkers before, she said, the blind leading the blind. So I don't know how I did it, but I actually let it set, the blind leading the blind, those two. But finally now that we do have it, somebody that's teaching you how to do, where to go, if you have barrier here, let's solve the problem. So like Ann mentioned a lot too. Now that I work in the dentistry for this many years, I know exactly how hard they've been. I walked in their shoes before, so I know. I know that, okay, the reason you can't come here because of all this fear. Could be you don't have insurance, the language is not there, who's going to take you there, and what do you expect it at the dental office. And so I make sure they know that, okay, I myself, I try to study what that appointment is going to be first before I go to tell you. So I usually will call ahead and say, what exactly this appointment going to be? So then I will be able to explain to the mom, say, when you go to the appointment, it's going to be like A, like this, B, like this, and C, like this, so they know. Because I'm not a type person that calls, okay, why don't you go ahead over there and they will help you. Because I read that before, and when you look around, nobody helped me. And you don't know how to ask to. Then you, forget, I guess. We're not paying too, so let's go home maybe next time. But I want to make sure they do. So I study first. So when they come to me, the patient, they come to me, I'll say, okay, here are the situations. You had a referral that you need to go to a specialty. With MA patient, they don't have a lot of choices too. They don't have a clinic out there that they can pick and go everywhere. They have to go to a certain one that take the insurance, and you probably know. They also are limited. They probably also selected your county and you have, Blue Cross Blue Shield, or Blue Plus, right? Blue Plus. But you live in another county, and the clinic that will take the special appointment will be, let's say, Ramsey County. They only take Ramsey County patients. So then you have no choice. But you're going to have to find again, maybe other one will take you. Or maybe you probably live down there, but there's someone up here take you, your insurance, so then you're going to have to travel. And so you're going to have to look for transportation with the parents, interpreter also for the parents. Make sure that they go to the appointments, they have all the what needed to be there. Otherwise, you only have one choice. And they one chance also when they got there and they don't have everything completed, they probably lose appointments. Okay, so there's a lot of fear that they have to go through. And also in my community too, especially, they thinking because all the children's teeth are children's teeth. And they're gonna replace adult teeth really soon. So I have to make sure that I understand why they say that and tell them the reason why. Because they don't replace it tomorrow. They don't replace it a month from now. So you have to make sure that you explain to them, okay, right here we'll replace it at certain year. And this side right here at certain year. And then toward the back at, some of the 12, 13 year. So at least they understand that, oh, okay, in that case, I'm going to have to take my kids and visit the dentist. Otherwise, they're going to wait until they have the pain. I even have some parents that come to us, and they said when they help their children brush their teeth, they know that they have to look inside so they can brush it, they can see inside to see what's going on. They only put the brush in and that's it. And so here, why, like my child couldn't eat, he said it hurts. When they look at it, it's already a big hole. And so they're thinking, doctor is a doctors. In my community, for the older generation, for the younger generation right now, they know the difference by dentist is dentist, doctor is a doctor, and who is who, right? What's your title and what you're doing. But they say, okay, now we have a pain, let's go to ER. They have a toothache, but they went to ER. And so ER said, well, we can't do anything, just your medication, you go back home and you go to dentist. And so they came to us. And I told them, I said, yes, dentists will do your teeth, but then medical doctors don't. And I have a really good story that I'd like to share a long time ago, okay? So for those of you that are working with anybody, please make sure you pay attention to detail when they ask you for help. Could be providers, could be social worker, could be schooling, could be anybody with a profession. I had this gentleman that came to me way back, and I would say many years ago, can't tell you exactly how many years, but I still working at St. Paul location. And it was early in the morning. We started at 8 o'clock. So he and his younger brother already been there right at 8 o'clock, so we can open the door at 8 o'clock. And he stood right there on the chair and waiting to see who I think he should talk to. And his mom. And so he probably looked at everybody coming down, but everybody looked like me, so I can't speak to him or her, right? So I actually was there going down to the meeting. So my skin looked like his skin. So then he confident that I'm mom. Then he speak mom to me. He go, "Nhớ trong tương quan," which would be, "Hello, sister." I said, "Hi." Then nhớ trong. I thought he had a appointment, so he just wanted to say hi to me, right? Then he go, "I brought my younger brother here to see you guys." I said, "Oh, okay, good. What is it that he had?" If I were just, in the audience say, "Yes, hi, sure. Why don't you sit down and sign it right here and they'll help you," right? I could just do that. But I'm not that kind of person. So I said, "Okay, so what can I do for you? What your brother here for?" "Oh, he had fever for the last several days. Then I'm bringing here to see you guys. And his parent doesn't live here, live in another county." I said, "Okay. What kind of pain? Just fever. No toothache? No." I said, "Okay. If only fever, you don't see here." But how, he doesn't know that. And nobody probably had told him before, let us say, that you don't have that information. And so doctor is a doctor to me. So he brought his brother in to see us as a fever. And what I mentioned before too, some parents also bring their toothache child to ER because hoping you can help if you're your doctor, that's it. So I said, okay, if he only have fever, we don't see here. He said, "Oh, okay, so what do I bring him next?" I asked him, I said, "Do you know any clinical, a medical clinical area here, maybe in this area?" He said, "No." I said, "How about Regional Hospital?" He said, "Yes." I said, "Okay. Take him down there. Take him to CPR at Regional Hospital." Then we left. Okay? So, my story to you is that just make sure that we pay attention to what they're asking us for. Make sure we get in the detail and just say, "Okay, oh yeah, I'm too busy. Why don't you go to this person right here that can help you?" Because they probably think, many times before they come and ask you. Like I said, many people had walked by and they didn't ask. And because he probably thinking that he's not capable of that question, asking me a question why. And so that's why he went until the last moment for that I walked by. Okay, so I'm really, grateful to be a CHW because I don't advocate for myself all the time. I try to advocate for patients. I also try to advocate for my staff. And my dad's actually a leader back in the back. So he always said, when you're leaders, you're actually the first slave. Okay? You're not the first president up there, you are the first slave. So which means that everything you do, you have to do for your surrounding first, for your patient and also for your staff. You don't want to have to work myself all the time. And so I probably have that, in here, 30 years ago when I came to this country when I was 15. So I would say that, my, information today for you are just make sure we really help them out. Even some for us, insurance coverage. To us, probably really simple. How come you don't know? But to them, they don't know because they don't know how much they got the coverage for. They only know that I have the insurance through the state. Do I know what else the coverage? They don't. And until you tell them, then they say, "Oh, that's how it is." And with this day too, they have limited. If you only 21 and under, you benefit all this and that. If you're over the 21, then you benefit all this and that. And so they don't know that part. So make sure when you refer your patient or anything, that will be covered under 21, make sure they understand the parents and the interpreter. So they can have that done before the child reaches the 21. I have just recently case that the mom came to me and I looked at it and said, oh, if that's the case, then yes, you need to be there soon because she will be 21 soon here. You're not going to get that benefit anymore for her. She goes, oh, nobody told me. I actually was an interpreter, so I can't say because you're an interpreter, or because you're a dentist, because you're a doctor, but I just said, then whoever your interpreters, if you need help with that, make sure you tell them that, make sure they go, make a point for you. So to take a child over. So then she has a benefit before she turns 21. Okay? And I see some moms right there, so that means you probably have experience, right? It is a lot, isn't it? Very difficult, for us to navigate it. And like I mentioned earlier too, all providers, and including doctors, dentists, whoever, they speak like I said up here. For us, you're gonna have to speak sometime. Even I try to speak, kind of fast, but sometimes I have tried to speak slow because I need to understand what he's talking. And we're talking too fast. And to me, I thought I already kind of slow. But I did a presentation at one point to ESL parents, and the teacher told me, slow down, okay, slow down more, okay? So make sure you slow down more and explain so in language that they understand. They probably yes, because kind of look at you, kind of intimidate a little bit. So sure, just yes, and then get out here and we'll figure out why. Okay, but then later on, you couldn't even figure out what's going on, what do I need to hear now, okay? So that is said, just make sure that we do help each other out. Welcome to let me know if you need some help. I've been there 13 years. Oh, not 15, it is 15 years, isn't it? Including with those that are with Dr. Peterson. 6 years as a dental assistant with Dr. Peterson and Dr. Peterson right there. Okay. I think that's all I have. Probably talking too much. You probably don't want to hear anymore. So let me know if you have some questions for me. Otherwise, then I guess I'm going to sit down, right? Thank you.
Thank you so much, Ann and Lou and Dr. Karp. We're going to go until 11:30, right until lunchtime. So please stay with us, or if you do have to step out, that's perfectly fine. Please feel free to talk to any of us over lunch if you have specific questions. We will have a little time at the very end of this panel for Q&A. And just to comment on Lou's comment from her dad, who, as you said, was a Klan leader, about first a slave, and I guess to me that kind of translates into what we call servant leadership, doesn't it? Putting others first in a leadership role. So thank you so much for mentioning that among all the other great comments that you had. I'm just going to share a little bit with you about our oral health roadmap, and maybe Dr. Karp could get my presentation up here, being a little bit more tech savvy than I am. But we passed out to all of you a report that was developed this year with support from the Delta Dental Foundation here in Minnesota. We're very grateful for their support, which really enabled us to look at oral health disparities in our state, to look at the research that's going on that really connects, exciting research that connects oral health with our overall well-being. And more we're learning, I think, what oral health professionals know all along, that for pregnant women, it's so important to have good oral health, to have a good pregnancy and birth outcome, that folks with chronic illness like diabetes or hypertension, or people with mental illness have oral health needs. So just more and more the research is pointing to the critical importance of oral health, and looking at some of the barriers to good oral health, and then how CHWs can begin to make a difference. Part of the oral health care solution So I'd like to just review a little bit about this project and our recommendations, and then invite your comments and questions in our Q&A here at the end. So the Oral Health Roadmap included in-depth interviews with stakeholders throughout Minnesota, in Greater Minnesota and in the Metro. It included some profiles of Twin Cities CHWs in oral health, including Lu Yang and LaTanya Black. LaTanya, you want to raise your hand here, who has been working with RSS in Minneapolis. Her work along with Lou is profiled. And then Danita New, who is here as well. As Lou said, Danita is a CHW working in oral health in the emergency room at Hennepin County Medical Center, where more patients than you can imagine present with untreated dental pain. So doing good work to connect people with a dental home, prevent that revolving door. We also looked at the research literature that links oral health and CHWs, realizing that there's a lot more happening in the field than we really see in the research literature, but pointing to an exciting programs like the one that Dr. Karp mentioned in Finger Lakes area of New York. So highlights of innovative programs in other states. We had a roundtable discussion at our Alliance meeting last spring to kind of bring these findings forward and help inform recommendations. So this report is also on our website for those of you who might want to share it with others. So our findings are ones that some of you are working with every day, that there are serious oral health needs and barriers among underserved populations, children, adults, older adults, people with chronic illness, people with mental illness, children and others with special health needs. That we know CHWs have an important impact on reducing health disparities, and our state really needs, we all know we need to do better, and so CHWs are part of that solution. And that there are opportunities to integrate CHWs into oral health care. So the good work that we're seeing now in places like Community Dental, HCMC, RSS, Portico HealthNet, Northern Dental Access, other places can become more the norm and not the exception. So I'd like to run through rather quickly these key recommendations and then look forward to working with many of you to bring these into reality. And so real quick, we would see employing CHWs to provide this culturally appropriate education and prevention services to underserved communities in many settings is very much needed. That we can pilot new models for integrating CHWs, such as perhaps an oral health hub that would supervise and deploy CHWs in multiple dental practices. If you have a small dental practice, maybe it's not feasible or practical to hire a CHW, but maybe a CHW could work with a collection of dental practices or be a resource within a chain or network of dental offices. Certainly engaging CHWs in boosting needed outreach and prevention, complementing the dental treatment and in-office interactions. We know that many dental practitioners are just enormously busy in their clinics and just don't have the time to go out into the community, and that's something that CHWs excel at, as you heard from Lou. Updating our Minnesota Oral Health Plan to promote greater implementation of evidence-based CHW strategies to improve health equity and a larger, more diverse dental workforce. So this is an opportunity as our state looks at our excellent oral health plan and has an opportunity to revise it and strengthen it going into the future. Good timing for that. A few more recommendations. Interprofessional dental education to increase awareness of the value of the CHW role and to build skills for team-based practice. And then just recently this fall, we were contacted to be able to link CHWs with dental assisting students, and would love to do more of that and to educate dentists and advanced dental therapists, and dental hygienists about the CHW role to really be able to build this kind of team-based care. We'd like to help transform the future of oral health by hosting an action-focused design lab for new practice models that build on the strengths of CHWs and the other emerging oral health roles, dental therapists and advanced dental therapists. Kind of put our design caps on and imagine what a future could look like to address those health disparities, utilizing those new workforce professions in ways that haven't yet been explored. We'd like to introduce policymakers to the benefits of CHWs in oral health and build support for sustainable strategies, integration strategies that address these gaps in care and advance the triple aim. And finally, to prioritize oral health in health plans and the new alternative payment models that include CHWs as reimbursable members of the oral health team. So we know that we have to look at the financing part as well, as I know has been an important focus in the oral health field.